for homeless patients in Westminster. Becca, I'll let you introduce yourself.
Hi, I'm Becca. I'm a Core Medical Trainee at the moment, currently doing renal medicine, and I don't think I can give myself a little summary, so I'll just tell you a little bit about my experience when we get to it.
Thank you so much, Becca. So yeah, basically Becca was my wonderful medical student back in 2018. We just realized it's nearly 3 years ago, and is well, doing incredible things, certainly more than I was doing as a junior doctor at that stage. So a little potted history of myself. I was at Imperial. I graduated in 2006. In 2005, I was here at Great Chapel Street Medical Centre. We'll talk a little bit more about it. It's been here since the late 70s as a surgery for homeless patients. I was here doing a specialty choice module in medical and social care of the homeless. And then obviously became a GP and was locuming here. And then, as often things do, it basically, the contract that had been run beautifully by Dr. Philip Reed for decades was put out to tender. And we formed a community interest company. And he's a director and mentor with us within that, and managed to win the contract by the skin of our teeth. And so been running it since 2018, which has been wonderful. But anyway, you know, we're here. So when we talk about health and homelessness, and I think the title kind of says it all, you know, it isn't just about inequality, it's inequity. You know, it isn't just about making sure that, you know, you've got access that's, you know, the same as someone who's not experiencing homelessness because of where they're at or what they're experiencing, or you know, everything they've been through. You've actually got to sort of overreach really and make sure that you're making even more certain that you aren't missing them out, and that you're getting to them where they are. Apologies as well, the Wi-Fi does this amazing thing down here in our wonderful windowless basement of cutting out. We say so much of homeless health is done in basements. It's sadly true. But yeah, apologies if that happens. It usually chucks me back in within a few minutes. So the next thing is, yes, why does it matter? Slides will all be available, very happy for them to be shared, etc. So, you know, everything we try and reference what we say. So homelessness, it's worth remembering that there is a huge iceberg. Rough sleeping is the kind of tip of it, but actually statutory homelessness, families living in homelessness is absolutely vast. And by far and away, the top cause of homelessness within the UK isn't substance misuse or mental health. It's actually loss of private rented accommodation. And that's where you get those kind of statutory homeless or homeless families within there. So as specialists in homelessness in Westminster, of course, we tend to see the rough sleepers, the people in hostel accommodation. So nearly 5,000 rough sleepers on a single night. But bear in mind, there's a count. When the count is coming round, there's a definite, you know, you want to look at, as a local authority, not just look like you're doing something. There is amazing work going on, but, you know, we know that they won't always pick up or count everybody that's out on the streets, not least because people are sometimes in places, hidden places, secluded car parks, places where it's not safe to go into and count people. So we know there are way more hidden homeless, even if just in terms of sofa surfers, people with, you know, kind of unstable accommodation, people at risk of homelessness, etc. It's rising. Unfortunately, everything within homelessness generally is just getting worse. Numbers have risen year on year since 2010. The number of deaths are rising. The only thing not rising is the average age of death, sadly, which has gone down, which is terrible. Rough sleeping risen 169% since 2010. There was a brief sort of plateau, I think, in 2019-20, where it didn't rise so much, but it's on the rise again. Poor health outcomes, high mortality rates. You know, I will talk a little bit more about this sort of frailty study that says, you know, chronologically, I might be 30, but all that's happened to me in my life, I'm actually more like the biological, you know, my body is more like a 60 or 70-year-old. So yeah, average age of death. For years when we did this talk and I had my quiz and do what's the average age of death, it's desperately sad. For a man, it was always 47 years old, and for a woman, it was 43. And then in 2019, it dropped. So, you know, 44 years old for a man, 42 years old for a female. And, you know, we do talk about the way whatever happens in homelessness and you're kind of mirroring perhaps what's happening in society. So I know Professor Michael Marmot, who I'm a proper fangirl of, who's done all the Fair Society Healthy Lives, who then reviewed that in 2020 to see what had happened. And actually, as a whole, the life expectancy across the UK stagnated. It's usually just increase and increase. So if life expectancy across is stagnated, what happens in our population? It just, everything kind of is affected more so, and the average age of death has dropped. And we just think that's just a terrible statistic, and one that we fight really to say, you know, every single one of them is a human life, is a person at some point was perhaps a young person that had, you know, whatever experience they had, hopes, dreams, and it's about bringing that sort of saying actually for each of them. And we know it can be complex and not easy. We truly believe that you have to sometimes advocate or fight for a person when there's nobody left, not even themselves, to fight anymore. So also, you know, from the point of view, we know not everyone is going to be a GP in homeless health, although do it, it's great. It's very specialized. I absolutely love it, but no kids, no oldies, are very much a sort of social type and kind of high level professionals meeting type scenario. I mean, there is loads of physical health and etc. that we see. But anyway, even if you're not, you know, as junior doctors, etc., almost certainly at some point you will experience this. And I think the main thing really is as well is looking at things like within, you know, you might be the junior doctor, etc. Oh, no, oh, so sorry, my lovely, thank you. My lovely Bando, our lovely cleaners, just taking my mug. But yeah, so you might be within a hospital team, you might have them on your team and thinking, this person's going to go back out to the streets. You know, I'm sure this isn't right. We'll talk a bit about, you know, some of the things that even if you're never going to specialize in this area, the things that you can actually help improve or just remember moving forward. So 70% of homeless patients discharged to the streets without their health needs assessed. You know, some people, although there is the duty, we'll talk later about the duty to refer, some people still discharge back to the streets, let alone with health needs addressed. 1 in 3 homeless deaths due to causes amenable to timely and effective healthcare. I mean, the top causes of death, you know, by far and away are, you know, I think they call it acute poisoning, so drugs, alcohol, etc. And then if you look at, you know, the drug and alcohol provision, not just within homelessness, certainly across the sector, it's something that's just been cut and cut and cut over time. And it's very, very difficult, certainly if that's happening on the whole, again, within our population that can find it difficult and have certain barriers to accessing this, it makes it even harder. Do we feel ill-equipped to address it as well? And I think, you know, that's it. Oh, goodness knows, it can be very challenging. It can be the last thing you need on your busy on call, or when you're tackling all the things you are, and you have somebody who's, you know, homeless, maybe has substance misuse issues, you know, and we know the behavior can be challenging, etc. This is just to give you an idea. London boroughs by number of rough sleepers. I should have put the next ones on. Basically, Westminster's up the top. It has been for forever and perhaps always will be for various reasons. But yeah, the next borough sort of, you know, closest to that, as you can see, was Camden, and then it kind of goes down from there. So the issue in Westminster, we'll talk a little bit about everyone in and what happened with COVID and getting people into hotels, but the flow, basically the flow to the streets never really stopped, even though we got people into hotels. But yeah, so that just gives you an idea of the scale of the problem and perhaps why, you know, there is a need for specialist homeless health, particularly in Westminster. But, you know, I think you can see, you know, it doesn't have to be, you can have, when we did the big project across all 8 boroughs of Northwest London, we found some areas had much more challenging, Ealing had a much higher proportion of very complex substance misusing homeless, etc. So, you know, you can't just look at the numbers, but often the funding will follow the numbers. So that can be really challenging as well for local authorities. So other forms of homelessness, remember temporary accommodation, huge numbers, you know, 56,000 households, we're not just talking individuals, in temporary accommodation. How stressful and difficult can that be? And in fact, as perhaps mainstream GPs, not specialising in homeless health. These families living in temporary accommodation, you'll see much more than we will, and with all those other issues that certainly follow. Hostel bed spaces, again, another thing that's dropping is the number of hostel bed spaces that we have. 40% local authority cuts. And again, we work so closely with our local authority colleagues, our rough sleeping commissioners here in Westminster, we have an excellent relationship with, and we understand the challenges that are faced as well from within, in terms of what they have to provide or what they have to work within. Homeless health. So yes, increased attendances, admissions, multimorbidity, it's not just physical health, it's physical, mental, social. One of the first things that we do is arrange I think we need an MDT. I think we need a professionals meeting. We need to call in social services, adults, safeguarding plus or minus if we have, acute safeguarding concerns, mental health team, substance misuse team, hostel service provider, street outreach worker, depending on who's working with them, bring everyone together and say, this person is going to be the next person who dies. How do we stop that? What can we do? What can we do to stop that? What can the person do? And, go from there. But often there are barriers that are faced, and you wouldn't believe them. Some of them, have improved over time, and some just worsen. We'll talk a little bit more about those. So yeah, proportion of those with physical health problems, mental health problems, drug or alcohol problems. I don't think any of this is really a surprise to anybody. This is, social determinants of health, proper Michael Marmot, fangirl. I sort of usually say it really, like, basically, look at those, look at social determinants of health, fair society, healthy lives, where he'll also compare different attitudes, different social structures in different countries, etc. But really, one of the things here, ACEs, adverse childhood experiences, the risk of becoming homeless in your lifetime related to your experience of adverse childhood experiences is just sort of exponential kind of relationship, really. And it's like the more, you suddenly reach a point where, you have a certain number of adverse childhood experiences, and it just goes through the roof. Poverty, deprivation, low levels of support. I mean, there is this, sort of saying, I guess, or what people say, we're all one paycheck away from being homeless, which in many ways we really welcome that narrative that actually for some of our patients, they are just have had really a really terrible, fairly normal life, and then something very terrible happened, massive bereavement or similar, and then life sort of derailed from there. But actually there was, I should remember who wrote the article that said, actually, maybe we're one paycheck away, but are we really? Most of us, because of our levels of support and social structure around us and family or friends, maybe there is somebody that when that one paycheck or the second paycheck doesn't come in, that we could turn to, and we have got a trustworthy and loving, if not exasperated with us that we've blown our money or whatever, kind of relationship around us, as opposed to just this kind of from childhood. Some of our patients, when they walk through the door and we receive a sort of stack of notes, and we start to look at them from when they were in utero and realize that there were so many odds stacked against them right from the start, that there was perhaps, that real, you could understand why they've reached that point now. So, I think that social support and structure is very much something that means that we aren't all necessarily wouldn't fall into it that easily, but similarly it can happen. High levels of barriers, rejection, perceived rejection, again, rejection perhaps in their own families or loved ones, and over and over and over again. And then, often we say in terms of self-love or kind of respect and shame, all of these things that kind of can come in rolled into one with the person, that can be really, really difficult to work with. And for however much it's very, very challenging, especially with a really challenging patient with, say, a personality disorder, we sort of say they live with themselves all the time. It doesn't mean you excuse, you shouldn't allow yourself to be treated anyway. We don't do, no, zero tolerance, they've had a bad life. No, you still have your standards, but actually a lot of our work is in trying to kind of not reach that point where things bubble over, and having that low barrier approach, and having that kind of that, you know, knowing that they're coming from a point of rejection. Some people we'll work with over years just to get them in to have an HbA1c to see if they're diabetic, and that might be what we'll achieve with them. We really want to try and go in and scoop people up at this point and decide what is it you need to actually get life to where you want it to be, but hopefully one that actually is one where you're going to steer away from this awful, you know, very, very young age of death and that sort of trajectory from there. And it's about giving those tools and making them available, and just hoping that, you know, if you throw out enough or reach out enough, that you'll just hook someone in enough. And I think this cycle, certainly low paid, poor quality work. I mean, we have a cohort of rough sleepers, absolutely, that, you know, are here legally, but don't have recourse or rights to any sort of benefits or any form of support necessarily. But work in terrible, you know, terrible jobs, etc. Some of them, if they have been trafficked, not here legally, then that's even worse. You know, people talk about, oh, illegal immigrants. And you think, actually, if you are illegally here, you know, and they say, oh, they come over, you know, illegal immigrants getting all the housing, and you think, actually, no, if you're properly here, you know, illegally, and you can't work legally, then you're not going to be just given a council house, etc. It doesn't work like that. And in fact, often they're in truly, truly terrible working conditions. And some are not, they're just in the lower paid jobs, which becomes this cycle of, like we said, ill health, etc. This was the study which looked at premature frailty, geriatric conditions, multimorbidity. I won't go, don't want to bore you too much with it, but it was basically looking at where they identified frailty and how high, you know, it was the equivalent of like an 89-year-old in the general population, which is why there was such a push for COVID vaccinations within this group, that you can't just go on the basis of age or necessarily diagnosed conditions. And this study was really key. And that's why we've just finished this absolutely bonkers program of getting out to every hostel, mental health and homeless health, because they often coexist and people have gone through both the pathways, to deliver COVID vaccination, along with our Westminster homeless health colleagues and another specialist homeless surgery in Westminster. Anyway, so, you know, you would look at it and go, this is what you see in a nursing home, except of course they're sitting there in a hostel. You know, which was in COVID times was such a worry. 8 or 9 of them sharing a toilet, lots of complexity, lots of frailty. So it was a real worry as to what would happen within our hostels. Anyway, so layers of poor health, again, starting, you know, just from those, why is sort of a lack of childhood surveillance, why is that a soft safeguarding sign for health visit? You know, what do we start to do from the moment we have all these little kind of milestones that we expect parents to do for their kids? And it kind of goes on from there. Reduced vaccination, reduced prioritization of their own health barriers, and then it kind of goes from there, leading to that ultimate outcome of extreme premature death. And so we kind of look and go, right, you know, sometimes we have reached the point where we've come in at multimorbidity and we're trying to just claw back from extreme premature death. But loads of our work is in basically throughout this snake, kind of saying, well, look, through education, through, you know, whatever it is we do, we try and lobbying and, you know, all of that to try and get all of this to change along the way. And yeah, this is just a very busy slide with some of the things that we see here. Yes, we had, you know, runs of, what we get, loads of strongyloides is something we've been seeing a lot of, which I had never seen before. My colleague Natalie put this together in terms of some of the medical, you know, so some people go, there is an awful lot of what we call sort of social medicine and this sort of higher level complex care as a GP in this setting, but there's also a heck of a lot of medicine within there as well. Certainly mental health. And we're really lucky to have a consultant psychiatrist who's been here the decades the post has been in. It's constantly under threat, but we're still holding on to it. But yeah, so again, just loads of things. Some things relate to the actual physical act of rough sleeping, not putting your legs up at night. You'd be amazed. It takes less than 2 weeks of kind of, you know, especially if you're a female, say using the night transport to keep safe and sitting on a bus and not raising your legs, for you to get cellulitis, etc. Thank you so much. Take care. And, you know, for then skin breakdown, etc. So anyway, you know, it's all the sorts of things we see. And yeah, that relationship between the three, and just simply, you know, personality disorder, is a huge part of what we see, and yet something that's really difficult to get into specialist support for. We do get people through, but it can be really difficult to get them to a place where they're able to engage with. Certainly that talking therapy side of things can be a huge part of the challenge. Heart disease, stroke, epilepsy, functional impairment 10 to 15 years earlier than you'd see elsewhere. And this is what we talk about, this kind of chronic morbidity cliff, and how that kind of just suddenly slopes and cliffs in health inequalities, comparative morbidity of housed and homeless people. So it's all within the Lancet. Do just have a read. It's makes for desperate reading. Homeless people attend A&E 5 times as much. So we've got some projects, for example, we've got some beds funded by Health, the CCG, within a hostel, that we can say, look, there's this guy, he's going in and out to hospital with horrific cellulitis that needs IV antibiotics. Can we bring him in? Can we do some targeted work? Can we get it when it's early, give him some antibiotics, and then basically try and get him so he does not return to the streets? That's our ICN project. And we've got another one that's for step down from hospital, where we can take them in when they've got a health need and basically kind of key work, etc. That money comes through the rough sleeping pathway, kind of a housing thing. So we here have got a few fingers in a few pies, but sometimes the thing that talks is this, I can bring your patient in, fund this bed for X amount, because actually if I bring them in and they don't attend A&E 3 times in a week, and we do this work, we've not only saved that, but we've also changed that trajectory for them as well. So that's why we often talk about those, the use of that A&E and the resource. And also, is it the best way? How do you think people feel when they come into A&E? How are they made to feel? It becomes sometimes a self-fulfilling prophecy for how they present, and it can be just a really dysfunctional interaction, and then they still leave with their health need. So yes, barriers, patient level barriers, practitioner level barriers. So here are some of the things. Registration, you just need to be a human being and breathing to be able to register with a GP anywhere, not just a homeless health GP. It's clear, CQC has said it, the NHS primary care guidance says it. You cannot refuse people on the basis that they can't produce ID or proof of address. You can ask for it if that's your policy, but you cannot discriminate against them just because they can't produce it. Yet time and again, we see GP surgeries, unfortunately, it's a lot better, and doctors of the world do lots of work in trying to improve that. Language, complex trauma, all sorts of things. GPs, patients turned away, NHS charging. We'll talk a little bit more about that. That's something that we're seeing a lot more from that sort of secondary care side of things. Anyway, this is my talk where I normally talk about this poster, but I will leave Becca. So this is made by wonderful Becca. In terms of, I think I'd said, no one is certainly sitting with us is just a student. This came about from, just incredible work and looking and saying, what can I actually do? And making it simple. You're a person, you're a doctor in A&E. What actually can you do? Have you done what's your statutory requirements? I'll let Becca talk about that. We talk about stopping the revolving door, just coming round and round and round again in the same services in the same way. And it's trying to pull everyone together. In homeless health, we're still guilty of being lots of siloed care, not bringing people together. So we're absolutely passionate about, 1 hour, good hour of bringing everyone together can actually unblock doors. You might not have any recourse to public funds, but you still have a right for a human rights assessment or other care needs. Social services have a duty. In fact, you've been trafficked or a victim of sexual abuse. Actually, you have rights that are given to you because you've been a victim of that. Sometimes that's the way in which you can unblock things. And a trauma-informed approach. Absolutely, it's almost ubiquitous across all of our patients that there's been some form of trauma that's led to them being here. Effective handovers, there's little things, homeless patient going away on QDS, flucloxacillin, and thinking they're never going to take that. How are they going to keep it? Making sure you're not giving things that need to be in fridges. There are all these sort of little things, certainly, that we can make differences all along the way. Looking at the person in front of you, are they on methadone? A quick call to their chemist to show, actually, yes, they are. And no, they haven't picked up today. And actually, if you do just do what the chemist tells you is their actual dose and write it up, they'll probably stay and have their horrific endocarditis start to be sorted or something like that. I just want to say about the HC2 certificate, don't forget that. Sometimes we feel we can't do anything, even if they have, you know, they've no recourse to public funds. You don't know about whether they're here legally, etc. You can still get an HC2 certificate because they're destitute and just rely on, you know, charity, etc. No money at all. And it means all their scripts are free. And it's something that, you know, our outreach workers have got really good. You can apply online now, but it's something, you know, hospital, unless you give them literally dispense from A&E, even if it's an outpatient, they can still be charged for things. And NHS Business Service Authorities, unfortunately, did a really cynical sweep of everyone with a day centre address and checked whether they truly were on benefits to get free scripts or not, and fined everyone. So this is something to remember. It lasts a year and it can be the single biggest intervention. And, you know, it's something to remember. Again, you're busy, you might not be able to apply for this online within A&E, I know, but telling them about it, who's your support worker, speak to them, scribble it down, HC2, and get someone to apply for that. And remember, because it's sometimes some of our patients who, you know, literally there's nothing else we can do. We can sort this out and then we can start to address their horrific diabetes, etc. And again, if they're on diabetic medications, there's different certificates you can apply for. Again, you know, you don't expect to know all of that, but it's these little things that sometimes we don't realize are never going to find £9, and they will get fined as well. It becomes this cycle. So yes, you can't basically get that if you're already on benefits. I mean, I could talk forever on benefits. I think it's just worth remembering that, you know, the majority of people in this country who are on benefits are actually in work. So, you know, just because you're on benefits doesn't necessarily mean you're not working. A lot of our patients are on that universal credit sort of incapacity, sort of sick side of things, what used to be ESA. But they can be means tested, non-means tested. People can be on PIP, personal independence payment, because of a disability, but perfectly capable of working, etc. So it's worth asking within there, are you receiving benefits? And, you know, again, you're not expected to know them all, but if it's sometimes it can be a case of just like, well, why haven't you? Some of our patients are just at a point where they've just given up on all of that. The benefit system has become increasingly obstructive and full of hurdles. So it can be that people have literally fallen out of that. So again, not going to apply for any of that for people. You know, key worker, day centres. Sometimes we have doctors calling us up, you know, and asking for advice. What do I do? I've got this patient. Sometimes a little intervention or thinking of something like that will make all the difference. Public funds, it's so difficult to assess. The slide of immigration statuses is huge. You can't even advise on it as a lawyer unless you have a specific qualification. So, you know, really, the implication then on secondary care and charging. So I don't know if you've seen this, there's a little amber alert that comes up now. If you've just been given an NHS number, it puts this amber alert on the spine. So as soon as I refer them in, the overseas visitors manager will be alerted at the other end to start to think about charging. A&E, life-saving treatment is free, but the moment you're admitted from A&E, you might be charged. Maternity care is supposed to be deemed as life-saving. You're not supposed to put women off receiving it, but we've had people, it was a lady of Roma origin who had domestic violence already under safeguarding, and unfortunately the overseas visitors manager tried to charge her for her upfront for her antenatal appointment. We had to advocate so strongly. Some hospitals do it really well and properly, some don't. So it's being aware. If you're there and think, actually, I don't think this is right. It needs to be the clinician decides whether treatment is urgent enough that you just deliver it and worry about the charging later. But remember, when they sign, they also sign a thing to say if they default on the payment, they're allowing the hospital to communicate directly with the Department of Immigration. That's really intimidating for people. So there's a process. It's there. We understand why it's there, but it's just making sure that it's done properly, that it's a clinician that decides. And we've had all sorts of sad situations, certainly a visa overstayer who had cancer, that they decided, although he'd gone in with hematemesis, acute bleed, stabilized, then they tried to charge him up front. If you're not from within the EEA, it's 150% of NHS tariff. So trying to tell this destitute man working in dubious conditions because he can't legally get work that he needed to pay 120 odd grand up front, and it just isn't going to happen. Doctors of the World, fantastic resource, fantastic advocacy. They've been great for us in terms of just making sure, you know, actually, you know, it might be that you're an asylum seeker, there are certain ways in which, you know, you should not be charged and should not be intimidated up front. Anyway, so yeah, like I said, there's all of these, access to all of these afterwards. Do remember the duty to refer. So local authorities have advice as well as relief duty. So there's this thing of local connection. Have you been in Westminster for 6 out of the last 12 months or 3 out of the last 5 years? you know, all of that. There is, as a hospital, so it came basically, public bodies in England, which include hospitals, have a duty to refer anyone you're aware is homeless. That's, Becca talks about that on her slide as well, about just notifying the local authority, even if they're just going to give them advice, you know, even if they're not connected to Westminster because they haven't been homeless for those requisite amounts of time, still have a duty to give advice. And this is it, mandatory duty for hospitals, including A&E, to refer a homeless person to their local authority. And there's the form. So we talked a little bit about, it's just to say that there is a whole, we can talk to the cows come home about what we did in the first wave. And there was the Everyone In campaign where the Magic Money Tree opened up for a bit and everyone flooded into these hotels, and we were suddenly there and delivering. I mean, it was incredible what happened, but very quickly the flow continued. Hospitality staff on poor 0 hours contract lost their work, could no longer sofa surf or be in very crowded sublet accommodation because everyone got fearful. So there was this big influx again of people out there. But the night shelters suddenly closed. So, you know, we used to have people in camp beds within Westminster at all of our night shelters. Suddenly, to the great distress of all the staff and everyone, they just had to shut, because if you had people in camp beds side by side with COVID rising up, you could just end up with it just wiping everyone out. Very costly, very effective, and very quickly became, well, no, there's no more of that Magic Money Tree. Now the local authorities have to provide from here. Second wave, unfortunately, hit our hostels certainly more so than the first wave had at all. There were thankfully very, very few cases, but not so. We had more cases from sort of December to Feb than we'd had in the whole of March to December of the year before within our hostels. And the Homeless Health InReach vaccination program, hot off the press, which is what we've just done, which was basically going in and delivering AstraZeneca vaccine within hostel settings to vulnerable populations. So yeah, real whistle-stop tour. Anytime, basically, we love to have students here sitting in. It might just be for a day. It might be coming to our Tuesday MDT. Again, that's virtual nowadays. It might be whatever it is, contact me. It might be you're somewhere and you think, I just need advice at some point about a homeless patient. Give us a shout. You know, we're really happy to guide. We know it isn't always easy to know what to do. We know it isn't easy. We've been doing this, the stuff I'm still learning, stuff I still don't know, but it can be those lots and lots of little things that you do that actually are the things that make the difference and help our patient at this point, maybe when you're seeing them there, that you can actually just keep them in or make them stay and just change the course of their life in that way. I will hand over to Becca now.
Hi, thank you so much, Dana. As I'm Rebekah, I'm a Core Medical Trainee, and it's a real privilege to have been invited today and to speak alongside Dana, who's a massive inspiration for me. So thank you. I will do that annoying thing of saying next slide. So thank you, Dana, for controlling the slides. Also, apologies if someone walks in, I'm in some random clinic room in the hospital. And just a disclaimer, I'm not an expert in homeless health, but I've had a little bit of experience at a junior level in the last few years. And my hope is just by sharing more kind of reflections from that experience, we can kind of think together about how we as students and junior doctors have a role in improving outcomes for patients who are experiencing homelessness, and also think a bit more kind of widely about what are the issues that are pushing people into homelessness and how can we use our position to be kind of good clinician advocates. So previous slide, in final year, I had the opportunity to do an elective with Dana and Natalie at Great Chapel Street Medical Centre, and it was really amazing to see firsthand the work they do with people experiencing homelessness, which, as Dana has said, often at the kind of intersection of a myriad of complex issues. It's amazing to see kind of how they work at interpersonal, kind of individual level, and also as clinician advocates, kind of challenging harmful policies, systems and structures which really act to kind of perpetuate disadvantage. Then I started work, next slide, in F2 I found myself working kind of in a busy central London A&E. And I was really struck with how poorly we were caring for people who are experiencing homelessness. So I, as kind of a relatively new doctor, felt really ill-equipped about how to deal with these complex issues. And I know a lot of my colleagues also felt the same way. So I linked back up with Dana and her colleagues and had to think about what realistically we were hoping to achieve in the A&E department for people who are homeless. it was a small kind of quality improvement project, and by no means had a big impact. But what it did do is it encouraged kind of me and my colleagues to reflect a little bit more about the issues facing people who are homeless, and actually challenge us to educate ourselves about what we should be doing and what services we should be signposting our patients to. Next slide, please. And then I moved from A&E to COVID medicine, as a lot of people did. And I was lucky enough to stumble across a professor in hepatology who does some really amazing work in prisons, in detention centres, in homeless hostels, and even on the streets, testing for and treating hepatitis C. He's a really inspiring kind of clinician as well, who's used his power to kind of leverage funding bodies and medical institutions to do better for people who we as a society often neglect. And he was kind enough to let me kind of come on board and observe some of the work they were doing. So that on the right is Lisa, one of the amazing hepatitis C specialist nurses who's been doing some great work, kind of visiting people on the streets and in hostels, testing for Hep C, and then initiating them on curative hepatitis C treatment, which is really amazing. And just a really great example of kind of tailored approach. So not forcing people to attend our traditional healthcare services, so need to come to clinic every 2 weeks to have your blood done and your Hep C viral load tested, but what can we do to meet you where you're at? So that's my experience so far, and I feel really privileged to have been able to learn from Dana and her colleagues. It's been an encouragement and a challenge, and given me lots of food for thought. So I guess kind of reflecting on those experiences, there are a few things which have struck me, many of which I know you guys will have thought about and which Dana has put so brilliantly today. But again, I just wanted to kind of think about some of these things out loud so that we can think about our role as junior doctors in this work. Some of these thoughts are kind of more general, and that's intentional. So as Dana alluded to, homelessness is a product and a contributor to other injustices. So for example, xenophobic and racist policies and structures, unjust criminal justice systems, institutions and healthcare systems which discriminate on race, gender, sexuality, etc. So these are kind of some more general reflections as well. So next slide, please. So firstly, there's the system factors which cause and perpetuate homelessness. And another slide, please. So I don't know about you, but in medical school, I felt like most of my training led me to just focus on the patient in front of me, rather than the bigger systems and factors at play affecting their health and welfare, which is really crazy if you think about it, because we just see the very, very tip of the iceberg as doctors. So that's things such as national economic, health and social policy, local government policy, and then kind of factors within the healthcare system. So we're not taught to be very critical of the system we operate in, but the way our clinical services are designed, the way resources are distributed, and whether or not there's flex in the system really affects our patients. I guess what I kind of mean by that is that in the NHS, we pride ourselves, rightly so, in offering kind of equal care through having a national health system. But as Dana mentioned, equal doesn't equal equitable, if that makes sense. So if we don't have flexibility to do more or do things differently for people who need more or need different approaches, then the outcome will kind of definitely be inequitable. And that's one of the hardest things I have personally found in starting clinical work. Then there's the complexity of issues which we find to be concentrated in homeless patients. So next slide, please. So as Dana said, physical health needs, mental health needs, social circumstances, and pre-existing trauma. And then there's the issues we face as care providers. So again, this is not meaning to generalize, but just some personal reflections from my own experience. Next slide, please. So firstly, lack of knowledge and education, both in our kind of formal education in medical school and postgraduate training, about pathways and resources for people experiencing homelessness. Or conversely, something we might not think about so much is the fact that we have a very fixed idea in our head about what it looks like to be homeless. So we neglect to ask the well-dressed young woman about whether she has permanent accommodation, whether she feels safe where she lives, and thereby really failing to recognise her needs and failing to offer her help. And then there's the challenge of kind of managing our emotions and expectations as healthcare professionals. So what I mean by that is, if I'm faced with someone with complex health needs, which I don't feel equipped to deal with, this has happened a lot to me, or if I'm faced with someone who's showing challenging behaviour, or if I see someone coming in and out of A&E week after week in a really difficult, sad state, I might have a number of reactions emotionally to that, which then affect my behaviour and my care. So if I feel frustrated about the situation, I might become kind of judgmental, or if I feel powerless, I just don't know what to do, then I might just actually disengage and be kind of apathetic about the situation. Or, you know, there's lots of stress that we deal with in our day-to-day life, which kind of makes us less empathetic and less compassionate to the people we face. And then additionally, something I've been thinking about recently is my expectation for gratitude and gratification. So I don't know about you, but if I'm really honest, part of the reason that I went into medicine is I like seeing a positive result, and I don't think that's uncommon. I think a lot of us, that's kind of a natural response in some ways. But it's not always possible when we face someone with really complex needs, or someone who's experienced really deep trauma that's left kind of really deep scars, to kind of have that gratification. That kind of desire or need we have to fix things or to be thanked can't always be met. And so we can't really rely on that as a driver to help people. And then lastly, kind of the challenge of seeing what lies beneath. So that's something I really thought about with my time with Dana and Natalie. And, you know, this is something which I find a continual challenge and continue to get wrong. But seeing kind of how professionals in homeless health really work on seeing the context and meeting people there, I find really inspiring. I think it's something we have to learn in so many other aspects of our practice as doctors too. So just a few more things, don't worry, I'm aware we don't have much time. So just some reflection therefore on what we can do about it. And this is reiterating a lot of what Dana has said. So next slide. So system level vote, we need to be political as doctors, obviously. Secondly, reflect. So think about how the systems and departments we work in do or don't serve people at the margins. There's a really amazing medical student who I haven't met personally, but she said something on Twitter which I thought put it really well. So she said, who do our systems serve and who are they centered around? And by that centering, who's relegated to the margins? And I thought that was a great summary of something we all need to reflect more about. And then thirdly, so seek to learn and gain experience, both in head knowledge about policy, pathways, local services, and also experientially through kind of observing and learning alongside people who work in this area. Fourthly, so engage with community organisers and organisations such as MedAct, which I'm sure you've heard of, and many others, too many to name. And by being here, it sounds like you're already engaging. And then lastly, act. So just because the issues are big and at a system level, it doesn't mean that you can't make a difference where you are and in your sphere of influence through kind of collaborating with others. And then next slide, at a personal level, so if we feel restricted by a lack of knowledge, I continue to always feel that way, then we have responsibility to educate ourselves, to know what services are available to our patients when we rotate around different hospitals, so we can empower them and we can do even just one thing out of the things we would like to do for them. And then if we notice negative assumptions and attitudes in ourselves or in our colleagues, we need to recognise that and challenge that. And then when you're caring for an individual who's experiencing homelessness, I would just encourage you to reflect on how you feel. So if you feel discouraged and powerless, think about what you can do. Remember that those individual interactions, though they can't fix the kind of wider issues, they still matter. And you know, a compassionate exchange, even if you don't see a positive outcome, matters in and of itself. Fourthly, reflect on context. So continually seek to gain an awareness of the wider circumstances which lead to a certain choice or behaviour. Name those stresses and factors for yourself, and sometimes I find myself documenting them in my clerkings just so that we bring those to the surface and we don't ignore them. And then lastly, manage your expectations. So this is something I'm trying to do now, but reflect on your motivation to do medicine and whether you do have a need, unfortunately, for that kind of gratitude and gratification, and reflect on where that's helpful and where that can be harmful. So those are just a few thoughts. And if it's all right, I'd like to end by reading you a quote which really has struck me. It's from a book by Brian Stevenson of the Equal Justice Initiative called Just Mercy, and it's actually about the carceral system in the USA. He's not talking specifically about homelessness, but more broadly about social justice. I'm not trying to rip off his quote for the purpose of this talk, but just because he talks really beautifully about what a just society looks like. So he says, "My work with the poor and incarcerated has persuaded me that the opposite of poverty is not wealth, the opposite of poverty is justice. I've come to believe that a true measure of our commitment to justice, the character of our society, our commitment to the rule of law, fairness and equality cannot be measured by how we treat the rich, the powerful, the privileged and the respected among us. The true measure of our character is how we treat the poor, the disfavored, the accused, the incarcerated and the condemned. And we are all implicated when we allow other people to be mistreated." So the reason I shared this quote is that personally, I think it's a real challenge to me as kind of citizen of our society, as a doctor in the NHS, and to me as an individual, about what justice looks like and who we value in society and who we care for. I think it's a good reminder about justice being both the means and the end that we are seeking in healthcare. And also a reminder to me that my work as a doctor is not how good a job I do for the sweet old lady who buys the ward chocolates and calls me an NHS hero, but how good a job I do when it's challenging to do a good job, when the patient's needs are complex, when I feel out of my depth, when I'm working in and against a system which is unfair, and when I do face those kind of more challenging interactions. That is where kind of I want to measure myself, and that's where I feel kind of it matters more, really. So thank you, and thank you for indulging some of my rambling reflections. I hope we have time for some questions if you guys want to ask questions, either here via chat or unmute yourself, or feel free to contact us via email, Twitter, etc., whatever you find most comfortable. So thank you again for having us.
Thank you so much to both of you. I think these guys are so busy, so we really appreciate you spending the time to talk to us. And it made me, I've realised throughout my medical career how political medicine is. And I think also you've just highlighted how important the multidisciplinary team is. So I know there's people here that aren't medical students, but policy, governance, all aspects of health and social care are just, there's so much that can be done. So thank you for highlighting that. And yeah, I think if you might have time for maybe 2-3 quick questions. So if you want to raise your hand, and we can ask you to unmute, or type in the chat and we can do some. And then the QR code is the link to the feedback form. Don't worry, I've got the link as well, so I'll share that in the chat.
So sorry.
I have a question if no one else has one.
Go for it. Thanks.
I was just wondering what your thoughts were in terms of supporting people that are homeless with their mental health. In my experience, there's been this kind of, the sticking point has been the fact that the majority of people have like a comorbidity, substance misuse with a mental health problem, and the issue comes when mental health services aren't willing to take them on until they address their substance misuse problem, but obviously they use substances to cope with the mental health problem. That's where I personally found people just get really, really stuck in the system, and I just wondered if you had any thoughts on how to go forward.
Yeah, it's a huge problem, and I think particularly it's sort of improved. So there was a point at which substance misuse services started to get in-house psychologists, which was a revelation, when that came in about, can't remember, it was much more common about 7-8 years ago. When that started to happen, because absolutely, I mean, the big one we're facing at the moment now as well is memory services and alcohol. So the memory clinic won't assess until they're 3 months abstinent. But of course, you know, actually, if they've got an alcohol related dementia, it becomes really problematic. So from our point of view, I mean, we're really lucky to have an in-house psychiatrist. So from our point of view, what we used to have was a mental health practitioner that was you'd come in here and you'd have that initial assessment where they would decide, well, look, do that initial assessment and say, okay, yes, you have a crack and heroin problem, but you are also might be suffering from PTSD, or you've actually got a concurrent depression, or you've got, actually, we think this is a low-level psychosis, is this a kind of serious mental illness type scenario? And so from our point of view, we are so lucky that you'd have that, and we could basically pop you in with our psychiatrist, who's able to then assess, and what it's about working closely together. So a lot of advocacy is needed, absolutely, where we'll do a referral through. I mean, if we didn't have our mental health, like our psychiatrist here, what would we do? Because we would hit against these brick walls. What you sometimes get is that addiction services have a psychiatrist, so they're not just looking at that addiction side, they're actually also looking at the underlying mental health. So I think it's hugely variable. Whoever runs the alcohol or drug contract in the area can be massively variable. But yeah, sometimes as GPs, you kind of are that central sort of tenet, really, and you'll go, well, yes, that's as may be, they may be using all these substances, but so sometimes as a GP, there's some things you can safely do, but you can't just chuck someone on an antipsychotic or do anything like that. Absolutely, that's something that needs psychiatrists. So from our point of view, we really advocate strongly for having that kind of psychiatrist embedded within primary care, but it's constantly under threat. And we know not even all homeless services in London have that. So there's lots of different ways. So you can actually, it's about, so we have our counsellors as well. So it's looking to see what are your options. So we have talking therapy. So there's the IAPT, a CBT type approach, but we have pre-treatment counsellors whose job really is to actually just work with someone at that pre-treatment level until they are ready to then engage fully in either more intensive psychotherapy or to kind of address that substance misuse need. So from our point of view, that kind of pre-treatment, very, very low barrier counsellor coming in, often a lot of what they do is sort of like a reparenting type approach. So yeah, absolutely. We really, really strongly, we're so lucky that we've actually got a strong kind of mental health lead within here, and that dual diagnosis that will just, you know, if nobody will start taking response or start taking them on. And it could just be that actually what you do is that you can just get them on an opiate substitution script, so they are using fewer opiates, for example. But other things, you know, I can't put you on something for your crack cocaine or for your spice. So yeah, it's a huge challenge. I think it's got better in many ways, but it can be about, basically, if the patient says, yeah, I think I might be able to do that, is having a really low barrier. Okay, I'll bung you in with the counsellors, they'll call you next week and at least start that interaction. Or actually, I can get you in to see our psychiatrist, because for some people, they'll feel, I'm sure I've got ADHD, or I'm sure I've got this. So I can't, yeah, I know we are incredibly lucky. And in terms of, yeah, carry on. Yeah.
Do you think that, I guess, like, my worry would be that some people don't hit the threshold for sort of secondary services and needing to see a psychiatrist, but obviously they might have been through something really traumatic or be like experiencing really bad anxiety or something. Do you think that there's a role for brief interventions that could be delivered by people outside of healthcare? Because that's what I'm sort of generally interested in. So like people that work
coming
in
in
night
from
shelters.
the point of view of like so not psychologically based, you mean?
Yeah, so people that aren't necessarily trained as like medical professionals. So, you know, the people that run night shelters and the people that run soup kitchens and that kind of thing, or outreach teams, whether there's a role for them to deliver quite brief interventions.
Oh, absolutely. Absolutely. And again, the one thing will be variability, and that if you start to look at brief interventions, which school of thought do you go for, what do you deliver? But yet from our point of view, the people on the ground, the outreach workers, the service providers, so night shelter staff, etc., the people that see them all the time. I mean, sometimes just the people on daily pickup, the pharmacist starts delivering brief intervention, you know, can you just tell him that I really want to see him for his awful legs, even if the pharmacist can't do that? So absolutely. And I think as healthcare professionals, what we don't want to do is we want to be speaking to, especially that kind of grassroots, and actually saying, yeah, you know, if you see them every day and you provide them with food or drink or sustenance, or that supportive ear, absolutely there is a role for sometimes just getting them to that point. Sometimes some of our soup kitchen or etc. staff spend a year getting someone to come to us to register. Yeah. So yeah, absolutely, absolutely. I think with everything, like with everything, it would be about structure and making sure with trauma particularly that you don't do more harm, because lifting the lid and cracking open trauma needs to be done in such a specialized way. So absolutely, it would be about, you know, having the right structure for that. But yeah, no, definitely. And it's something that, you know, especially when we were suddenly out in the hotels and working with all these people who were suddenly no longer in the night shelter over there, they were literally in the hotel now working with us, and we had people in chaos that couldn't get their alcohol, their drugs. You just realized what skills they have, certainly from just that human connection level. Yeah, absolutely.
Thank you.
Thanks for the question.
I think sadly we might have to call it a day there, because I'm aware Becca has a night shift starting in about 10 minutes. So we'll let her go.
Right, Becca.
I know. But just to say, actually, next Thursday at 7 p.m, our branch for SFGH and the King's Think Tank are doing a Twitter hour. I've never done one before, very excited. All about what we've been talking about. So how can we try to overcome the barriers to healthcare for homeless individuals, especially in this new normal that we are hopefully soon transitioning into. So that would be great if you join us there. The details are on the feedback form. And then other than that, next Tuesday for our 4th event, it's gender-based violence and COVID-19, very interesting. So the emails will be sent out at the weekend. And yeah, other than that, thank you very much for joining us. And yeah, please don't hesitate to get in touch with Becca and Dana or us on our socials. So yeah, just thank you again to you two for this lovely, amazing talk.
Thank you. Thank you for having us, and such kind words in the chat. Thank you, everyone.
Thank you very much. Have a good evening.
And thank you, Becca. Bye, well done. You were brilliant.
Take care. Enjoy your leave.
Yeah, good luck on nights.
Bye.